Well, good afternoon, everyone. I have 1 o'clock, so we will go ahead and kick off our call for today. Welcome to APIC Great Lakes November Education Webinar. We're thrilled to be able to offer today's presentation and are so grateful for Jenny, our presenter, for suggesting this really important topic. So my name is Kelsey Ostergren. I'm joined by Chow Nguyen, and we are the APIC Great Lakes Education Co-Chairs. I'm sure you've seen a lot of us, but we're glad to be back today presenting another great session. So before we get started, I wanted to just do a couple quick reminders for the day. So first, if you are an active member, please be sure to vote for the 2023 APIC Great Lakes Board. Voting will actually close on Friday. So take a few minutes before Friday to make sure you cast your vote. You should have an email from Denise Parr, who is our APIC Great Lakes nomination chair, with more details, the full ballot, and the link to vote. If not, let us know. We're happy to forward that to you. And then the second reminder, sort of along those same lines, is we are actively accepting nominations for our Red Blazer Award. So if this is not something you're familiar with, it recognizes the year's most extraordinary APIC Great Lakes member who personifies the trailblazing spirit of Judine Bartley. If you win, there's a couple cool prizes. So you can either get a free 1-year APIC membership, national membership plus free attendance at all APIC Great Lakes programs, or you can do $225 in APIC store credit, plus also free attendance at all of our APIC Great Lakes programming. So if you do have someone in mind to nominate, please complete the nomination forms and submit those to Noreen, our president, by end of day Monday, November 28th. The nominations forms were emailed by Rachel Ellens on 11/8. So again, we put the names and the dates in there, so hopefully you can go back and look. If you don't have them, again, let us know. We're happy to forward those to you. So with that, I will introduce our speaker for today. So as I mentioned, we are joined by Jenny Gubler, who began her career working at the City of Detroit Local Health Department in the STD clinic and eventually transitioned to a communicable disease investigator position. As the public health evolved in the City of Detroit, Jenny evolved with it, transitioning to the Michigan Department of Health and Human Services Communicable Disease Division as an epidemiologist. From there, Jenny transitioned into hospital infection prevention and control and has worked at DMC and Henry Ford Health. In 2019, Jenny became the manager of Henry Ford Health's newly formed Ambulatory Infection Prevention and Control team. And Jenny has a master's degree in molecular phylogenetics and systematics from Central Michigan University and is certified in infection prevention and control. So with that, Jenny, welcome. We are so happy to have you. The floor is yours, and feel free to share your slides.
Awesome. Thank you so much. Everybody bear with me for 1 second while I get this going. All right, I'm going to put this into presenter view. So let me know if there's any issues or you can't see that.
Looks good, Jenny.
Okay. Perfect. Awesome. So thank you everyone for attending today. Thank you for having me, APIC Great Lakes. I really appreciate the opportunity. I know this is kind of like up and coming, like hot topic information that everybody was really looking for out there. So I'm happy to help provide any information we can. And even though I'm the one doing the talking today and presenting, this work is not something that I have done alone. This is really something that takes a village. So I want to acknowledge my team as co-authors. So I think many of them are on the call. I've also sampled from some of their slides. So just a big shout out to them because this is really a new thing that takes a lot of people, a lot of trial and error, and a lot of patience. So we'll start out. So I have a little bit of an outline here, and I want to offer a disclaimer. So I know that people are really hungry for this information, and I wanted to try to provide as much useful, valuable content to everybody as I can. So there's a lot of content within these slides that'll be provided to you after the talk. So I probably won't talk about everything you'll see on the slides, but you'll have them for a resource later if you want to reference them. And then I also have our contact information at the end if you have additional questions. But the general outline of my talk today is I'll kind of give you a little bit of background on Henry Ford Health, just so you can kind of calibrate, like, how do we compare to you and what I'm talking about. We might be bigger, we might be smaller, might be completely different. And then we'll talk a little bit about ambulatory in general. It's very different than acute care where most of our IPs are located. So I want you to kind of have that awareness and kind of maybe lower your expectations a little bit if you're entering the ambulatory arena and you're used to the acute care side. And then we'll talk about how to kind of start building a program, where to go, helpful tips and tricks that we've learned along the way. A lot of this, again, is just trial and error. So we'll tell you what's worked for us and what we would recommend. And then we'll focus on kind of like, what does it look like day to day as an ambulatory IP, since it's very different than acute care IP. And then we'll just do like a quick little woo-saw type wrap up and takeaway. So if I kind of start diving in here, so Henry Ford Health, we have 33,000 employees. So just kind of to emphasize or kind of help you establish the size here of our system. We have 5 acute care hospitals and 1 behavioral health hospital. So if you look at this map is, it's a bit old and outdated, but it will give you kind of a sense of, we have this north market, a south market, a central market, and then each of these red dots is one of our acute care hospitals. And then our behavioral health hospital is like right over here above this guy. In terms of our ambulatory footprint, it is pretty large. A lot of other people that I've talked to from different systems are kind of overwhelmed by the size of our ambulatory footprint, or people that we've had come from other systems into ours are like, whoa. So this little picture here, this kind of shows you where all of our medical centers are just within like Metro Detroit, but we've actually expanded across the state of Michigan. So like last week, we were actually at a specialty outreach clinic in Grayling. We have one coming to Traverse City. We have some in Grand Rapids and Lansing. So we're really expanding our access and our footprint. If you were to look at our kind of catalog or list right now of all of our sites, we have about 150 plus buildings. And then within there, we have over 1,000 clinics and procedural areas. We also have 7 ambulatory surgery centers, 5 freestanding EDs. So those are in addition to the EDs that are already attached to our hospital. And then we also have dialysis, home care. We have some retail stuff with Optimize, like the eyeglass company. And then we have a large Henry Ford provider network. So those are private providers who are kind of affiliated with Henry Ford. So they use like our EMR, our lab, our radiology, all of those type services. So, and just to preface this, I don't know who's on the line and what your experiences are, where you come from necessarily, but when it comes to dialysis, home care, or the retail, we as my team do not actually cover those yet. There's some like politics and finance type things involved in that. So I'm sure eventually we'll cover them, but right now we won't. So I won't really talk about that here. We have provided them kind of consultative support throughout the pandemic. So we're somewhat familiar with them. So if people want to talk offline about that, we are totally open to helping in any way we can. Just to make it fun, if you look at all this ambulatory stuff, it's divided across 6 different operating units within the 3 markets, and then, as I said, also throughout the state now. So it just makes it, extra fun to navigate the politics, the different administrative teams, things like that. And then our team, as you saw on the first slide, is 4 people. So originally we formed in 2019 as me as the lead and 2 other IPs. And then since the pandemic, has been ongoing, I've been upgraded to a manager, and then we've added another IP, which has been amazing. And right now for Henry Ford, our team covers about 65 to 70% of ambulatory. The rest, the remaining portion, is either covered by no IPs, unfortunately, or some of the hospital IPs, and we consult with them frequently to help them out. So that's kind of where we're coming from with the content of this talk. So moving into just kind of a general overview of ambulatory. So if we talk about infection control as a whole, like I think historically we would all agree that it's been a very inpatient focused practice. However, the winds are changing. So ambulatory is really becoming the wave of the future for healthcare. Like the hospitals will always be there, right? But leadership in these hospitals have really discovered that there's a lot of untapped money and potential in ambulatory. And this is kind of like how people want to receive their care and access, right? We need to improve access as much as we can. So what's happening is healthcare systems are expanding their ambulatory footprints. I'm pretty sure, every major system on this call can say that you're building something or you've recently built and opened a new building. And the hospitals are also decanting a lot of their minimally invasive OR-based procedures, that they've traditionally always done at the hospital, to the ambulatory surgery centers. So hip and knee, like total hip and knee replacements are huge right now. They're really becoming an outpatient same-day surgery and discharge procedure, which I'll talk about in a little bit. But then in addition to that, there's a lot more regulatory oversight that's being applied to our ambulatory settings. Anybody who's gone through a Joint Commission or CMS visit or survey recently knows that they're starting to ask questions. When we had our West Bloomfield Hospital surveyed a few months ago, I was in the IC session. I introduced myself as the manager of ambulatory IC, and the surveyor was just blown away. Like, how amazing is it that you have, invested in this type of resource, that you can see that this need is coming. So that was really, heartwarming and good to feel in here. But in addition, I don't think I really need to tell anybody on this call, right? We have lots of vaccine preventable illnesses that are increasing more and more a little bit each year. And then I don't know about you, but I feel like every month there's some new either emerging special pathogen or like something that we, are already familiar with, but is, reemerging and surging, kind of like RSV right now or monkeypox. So you need people dedicated to the ambulatory arena to help the ambulatory people with all of this. And that's kind of what we've been doing for the past few years. So I don't want to scare anybody or make it seem like, oh, ambulatory is better than acute care, because it's definitely not. I just want everybody to be aware that it's different. And just kind of, if you're an acute care IP and you're either like, your system is forming an IP, an ambulatory IP team, or you have new people dedicated to do those types of things, I would just ask that you express a little sympathy or try to feel a little empathy for them, because it is different and very challenging. When you work in ambulatory, it's very much like trying to herd cats. It's a lot less organized and much bigger than what you're used to dealing with at the hospital. So just kind of keep that in mind as you go. I want to kind of compare for you kind of the differences, the key takeaways between inpatient and outpatient on the next couple slides. And I think this is really, really important to know if you're entering this arena, to kind of set your expectations low or different a little bit, because it's going to be very challenging to navigate this work. So if you think about inpatient, typically everything is just on one campus, right? You go to work, you go to your office, your desk. If there's, a flood or some type of emergency, you can just get up and run right to it. With ambulatory, you have all of your sites spread out along a huge geographic range. So it's not easy to just, get up and go help them. You have to do a lot of things electronically by phone, email, FaceTime is huge. I'll talk about that in a second. So keep that in mind. Also with hospitals, you typically have lots of dedicated resources, right? Supply chain, infection control, risk, employee health, emergency management. You're not going to have that with ambulatory. A lot of the ambulatory areas are supported by the hospitals, and they often fall through the cracks or don't get the support they need because the hospital people are busy doing hospital stuff. Another one is housekeeping. So, we are the people who are always worried about cleanliness and who's cleaning things and how we're cleaning them. At the hospitals, obviously, you have dedicated staff, whole teams of people that do that. With an ambulatory, it's usually the clinical staff who have to do the cleaning. You don't have a ton of dedicated housekeeping support, which makes things really challenging. And if I showed you our blacklight data, you would be like, whoa. In terms of communication, this is another one that we really struggle with. So at your hospital, you probably have a PR person who you shunt the information to, and they blast it out to everybody, and they get it, if they read their email. With ambulatory, you often have to create your own distribution list and maintain them, as you go. which is hard. Like, for example, us, we don't have a dedicated ambulatory PR person. I am the PR person. So if we have like a policy update that's going out, something that gets messaged on, I'm usually the first one to send it out and message on it at our morning huddles. There's also a lot of confusion sometimes in mixed messaging. Like if some of the ambulatory sites are associated with a hospital, the hospital might send out communication, the ambulatory people get it, and they're like, oh, do I do this? Do I not do this? And then Jenny sent me this email that says something a little bit different. So it's very hard to kind of navigate that. A couple more things. So in terms of ownership, usually it's really clear at the hospitals, really not so much in the ambulatory setting. And then when we talk about staffing, so if you're at the hospital, you're thinking of lots of nurses, providers, and maybe a few MAs or NAs. It's kind of the opposite in the clinics or in the procedural and ambulatory areas. So we have lots of MAs working side by side with the providers in the clinics, and we have few nurses. So we often have like one nurse manager who's over multiple clinics, and then it's just the MAs at the front line with the providers providing the care. So it's different, right? Because the licensing is different, scope of practice is different. You can't have MAs do things that nurses do sometimes, so you have to switch up your expectations in how you do things. So standardizing processes is always, I know it's challenging at the hospital. I've worked in patient IP, but it's even more challenging in the ambulatory because there's just so many more people. So for example, our Henry Ford Medical Group, which is like 40% of our ambulatory footprint, has more than double the amount of employees that our biggest hospital has. Plus we have all the providers to add on to that. So it's a lot. Policies are usually written for the hospitals by the hospital people. So it's when the ambulatory people pull up a policy, they read it and they're like, well, for me, this is trying to stick like a square peg in a round hole. That's a very common phrase we use in ambulatory. So sorry if you hear some background noise. My neighbor is having a tree cut down. This is kind of like my luck and how things go. So I apologize for that. And then when it comes to surveys, so, everybody's used to preparing for your Joint Commission survey every year, maybe the occasional CMS or something else. But at ambulatory, we usually have to prepare for even more. So I'll talk about this a little bit at the end, but since we support ambulatory and there's ambulatory sites associated with each of our hospitals, we participate in every one of those hospital surveys. And then additional things happen too, like our ASCs have their own accreditation. So we deal with state CMS on a regular basis for things like that. Final comparison slide. I know I'm getting a little bit boring. I'm going to move on here in a second, but leadership is also very different. So it's usually a nice little hierarchy for the inpatient folks, right? You have your CEO at the top, the rest of your C-suite, and then leaders, directors, and managers from there. In outpatient, it really just looks like it's so complicated. We often don't have org charts because they would just look like a bowl of spaghetti. So kind of keep that in mind. When you send an email and an update or an audit summary, you kind of have to think like, all right, who are all of the hundreds of people I need to put on this for awareness? And then I think a final thing that we've really had a challenge with throughout the pandemic, especially, is employee health or like occupational health services. They're usually located at the hospitals. They are not located out in the field at the medical centers. So medical centers have to figure out like which employee health do I call? Okay, I've had an exposure, I need to be seen, or I have some problem with like the hand sanitizer. Now I have to go to the hospital to be seen. It's a real challenge. Sometimes they'll set up like flu clinics and things like that and come out to our sites, but it's not a readily available resource, unfortunately. So that's kind of a general overview. I hope that did not sound negative. It's different, and I think it's important to be aware of that when you're doing this work. So if we start talking now about how to actually build an IP program, so this is probably what you're here for today, or your managers that you're going to send the slides to are going to want to hear about. So staffing is huge. Just like with any other group doing infection prevention and control, you can never have enough IPs. Whatever number they give you is great, but it's probably not going to be enough. So you're going to have to keep fighting to get more. But hopefully that will come with time. So there are a couple of things that I've talked with people about over the last few years as I've done presentations on this work and kind of consulted with other people. The job application or the job description is one thing that I get a lot of questions about. If you could customize your job descriptions and applications to specify that it's ambulatory, I think that would be very helpful for you. I did include a little box here. I won't go through all of it, but these are kind of things that if you can work them into a job description, it might be a good idea to kind of like help weed out people based on their interests and things up front. For us personally, we use general job descriptions. So if I'm hiring somebody, I have to like call them and explain, you know, like, yes, I would like to interview you, but just so you're aware, this is an ambulatory position, not acute care. So this has been a problem. Like if I wanted to hire someone straight out of like U of M CHIP program, they often have like big expectations and assumptions that they're going to get a hospital job. That's what they're looking for, right? That's what they've been trained for. So it's not always desirable when I call and say like, hey, I have this really cool ambulatory position that, you know, if you're interested, I'd like to interview you. So I've had people decline interviews for that reason. So if you can put the ambulatory word out there, that's definitely helpful. Also that it's more of a remote or hybrid position than it is, you know, like in person, like you usually have at acute care. It's also really important to make sure that people have reliable transportation because you're going to be out and about on almost a daily basis, commuting to different medical centers. And then mileage reimbursement is really important to make sure that your organization will offer that because you will put a lot of miles on your car. So when you're hiring IPs for ambulatory positions, it's probably similar to acute care, but it's really important to make sure that you're hiring people who are self-starters and who are flexible and can adapt quickly. So for those of you who are Friends fans, you know all about the pivot. I think the pivot is key when we're talking about people who can do this work. So we've all, like, if you're working in the hospital, you know what it's like to be working, you know, doing some surveillance, and then you get a call about like, you know, the OR is flooding or, you know, something bad otherwise is happening and you have to drop what you're doing and run to that. So we have to do that too, but we also have to get in our car. And then while we're driving there, we have to be like providing guidance over the phone about what to do to, for the people who are on the ground. So for example, these are actually real pictures of one morning where we're getting ready for huddle and we get this call that someone has driven their car into one of our wound care clinics and they didn't know what to do. So we had to provide them guidance over the phone, get in the car, drive there. So this is a situation where like FaceTime can be really helpful. So if they are at the front line and they can FaceTime you and show you what's happening so you can like actually see, you can provide much better guidance in the moment. So if you could find it, somebody who can establish boundaries and practice self-preservation, that's probably also a good thing. I don't think any of us are good at that, but I'd put that on the like preferred list because you don't want to burn your people out, but I think we all face that problem daily. A couple other things to kind of think about or try to implement that will be really helpful. So when you start this work, very overwhelming. There's just so many locations, there's so many people, there's so many things going on. You have every specialty under the sun that you have to deal with, and they're all doing little bit different things. So I would highly recommend starting with a catalog. So make yourself a list of all of your sites, and then just start adding columns of, okay, what are the different clinics in this building? What are the, you know, different services? Are they using soiled instruments, or like, are they handling soiled instruments? Are they doing any type of HLD? Who are the leaders? Who are the administrators? Maybe key like frontline staff to talk with about different things, and just keep adding to that as you go. It'll make it a lot easier. And then you can also use that catalog to build like kind of like audit tracking tools and things off of later. And then just as a heads up, you're going to constantly discover new sites that you're over that you didn't know existed. And you can just quickly like add them to that list or that catalog. I would also highly recommend getting or creating a group email address. So this is ours. I'm happy to offer it up. And I would teach people and advertise this address. So if you're sending out educational materials or messaging on anything, include, contact our group email. Teach people and train people to contact you to the group email rather than just like everybody, emailing Jenny. I personally have like over 1,000 unread emails on a daily basis. It's a constant battle. So they're not always guaranteed to get a response from me, but we do each own like a specific day of the week where we manage the group emails. So if they respond to or email our group email, they're guaranteed a response within 24 business hours. So that's been a huge help, especially throughout the pandemic. The other thing I kind of alluded to earlier is create yourself an infection control ambulatory listserv and just add people to it as you meet them. So if you need to distribute like an update on a policy or some type of piece of education you've put together, you have that list to go off of, in addition to anything else you might have access to. Other things, so I'm sure many of you are used to having like an on-call phone and rotating, that piece of work. For us, it's really hard to just have one phone. We tried that, but then you'd have to like go and meet somebody at like a park or like a McDonald's to exchange the phones and stuff like that. With the pandemic, they actually just gave us each of our own phones so that we could be answering more questions more freely. It's really helped with all of the construction work we're doing and talking with different contractors to have a dedicated phone. I know a lot of people are doing away with this or talking about this, so you might have to navigate this a little bit differently. But if each person could have their own phone, and then you could list all of those numbers as either on-call numbers or get something like, the Google number where they call one and it will kind of call everybody. Something like that is highly recommended. And when you have that type of phone, you should also set the voicemail up to redirect them to other, the other numbers if you can't have them all interconnected. Ours are unfortunately right now are not interconnected. They just have to call, 4 different phone numbers. So each of our voicemails does direct them to the other lines in case we can't answer at that time. Getting a website to share information is also a really great resource, and it will save you a lot of emails and phone calls if you just teach people like, hey, you have this ambulatory IC website. We post everything here for you. Go here first if you need something. And that's helped quite a bit. If you can start getting yourself added to like leadership meetings, get added to like the daily huddle report out, all of those things are going to help build your presence and kind of help people make them aware that you exist, number one. And you can start educating that way and get more involved. And get people to kind of buy into what you're selling, right, and promoting in terms of safety and the work that we do on a daily basis. And then also one critical thing I would definitely share with you is since you would be out and about at different medical centers, as soon as you set up an appointment or get an appointment forwarded to you for something on site somewhere, make sure you block off like the time before and after that appointment for commuting. Not only will it help you with mileage tracking, but you want to make sure you have that protected time. Otherwise, you're going to have to do meetings and things from your car, which we occasionally do, but it's not always ideal or safe, right? So keep that in mind. And then also just to point out, the time you spend commuting does unfortunately eat into your like email time and work time. So that's just something to be aware of too. A couple of other things. So this is going to be big, right? This is like a life's work right here. So what you want to do is when you first start, you're creating your catalog, you're kind of setting up your team and things like that. Make a master list of all of the things that you see. So I would highly recommend trying to go out and get eyes on all of your sites as quickly as possible, just so you can see what you're dealing with, the amount of variability you have and diversity of different processes and services. So make one major list and then start to divide it up into like your short-term and your long-term to-do lists, and just kind of prioritize from there. A lot of times you're really just going to be putting out fires. You're not going to probably have a lot of time, especially initially, to work on big project work. So that's still a problem for us, and we've been doing this for like several years now already. So other things, so we definitely divide the work up among the 4 of us. So it's usually easiest to divide it like regionally or by building, just in terms of like, you know, EOC rounds, if there's a flood or construction project, something like that. But then sometimes we do special projects with like a whole service line or department. So even though, like, for example, with our team, we each have our own buildings and sites and things like that. But for example, Jason's working on a project with ENT and SIDEX. So he's actually going to all of them. So he might be going into some of our buildings to do education with that specific clinic in that department. So there'll be a little overlap, but dividing the work up is usually pretty good and easy to do that. Couple other things. So as soon as you can, try to obtain org charts and contact lists of everybody involved with your sites and your ambulatory departments and facilities. So you're going to need things like the facilities department, the departmental leadership, if there's like a building manager. Just for fun, there's usually also like leased buildings. So you might need to speak with the landlord sometimes. So you need to know who that is. So keep that in mind. When you're working with ambulatory, you're also going to really need to learn how to work in the gray areas. Things are nowhere near as black and white as they might be at like a hospital. So just get comfortable with that and kind of just try to roll with the punches. So I kind of mentioned earlier that this is what, you know, a nice little organized inpatient org chart might look like, but this is definitely what outpatient looks like. So it's definitely a bowl of spaghetti or like a couple of yarn balls smushed together. So this slide and the next slide are just kind of a list of the different like spectrum of settings and types of care that you're going to encounter. Maybe not all at once. Maybe you have a smaller ambulatory footprint, so you're only dealing with some of these. But I feel like most systems are expanding to include as much as they can. So you'll have things like ambulatory surgery centers, emergency departments, clinics, procedural areas, maybe like specialty buildings, like we have a whole building that's just a cancer center. And then maybe things like home care, long-term care, dialysis, all of that. This right here is a list kind of for you to start with. I don't think this is in any way like an all-encompassing list of different departments, but these are all the departments that we work with on a daily basis. And each of them have like anywhere from like, I don't know, 6 to 8 different sites throughout our range in our area. We did put a little asterisk here as the key areas that you might want to focus on for reprocessing, which I'll talk about in a second. But that again is also not all encompassing. So that's why it's important to get out there to the front line, see who's doing what, because, you know, SIDEX use may not be restricted just to like your scope areas. There might be like somebody in allergy with a mouthpiece who's putting it in SIDEX. So I'll talk about that a little bit more in a second. And then those were kind of all the traditional like healthcare, doctor's office type things that you kind of think about. But there, you know, is this push to do an improvement or access to care. We're all, I think, trying to embrace like diversity, equity, inclusion, promoting, you know, better access to healthcare for everyone in the community. So there's probably also other services that you might get tapped to support. So we have lots of school-based health clinics. We have mobile clinics where people like, you know, are in vans or trucks and they're going out to service people in their homes. We have lots of community partners that we work with, like the Detroit Pistons. We have like large universities or businesses in the area that we support, like GM. And then to even get a little bit weirder, you know, in special times of need, sometimes you'll be asked to pop up like a large vaccine clinic, you know, like we did with Ford Field. And then we also do like lots of faith-based organization work where we have people going out into the field to give things like vaccines, do other like healthcare checks, clinical trial type work, and we support all of that too. So that's something even different, more different to think about. So if we talk about our day-to-day activities, I think this is probably what many of you want to hear about. I'll do a little bit more detailed information and things to look for. And this might be a good thing to kind of start with if you're creating IP positions or you're recruiting for IP positions to kind of share with any of your candidates. So this is kind of a general list of the things that we focus on a daily basis. I don't think it's all encompassing because weird things happen all the time. But ambulatory is definitely an onion. Once you get in there and you start working on things, you're going to start peeling back layers and layers, and you'll add to your list. But this is kind of our day-to-day. So I'll talk a little bit about each of these as we go along. If we start with cleaning, disinfection, and sterilization, so this is really our like everyday foundation. I think this is what we probably spend the majority of our time on. Or if we were to look at our time breakdown, like, you know, little food pyramid style, the base of that food pyramid for us would be cleaning, sterilization, and disinfection. So if we kind of break this down into the three parts. So in terms of environmental cleaning, I kind of already mentioned that a lot of the clinical staff are the ones responsible for doing cleaning in ambulatory. You don't have a lot of dedicated housekeeping or environmental services people to do that. So it's really important to make sure that you're kind of assessing like, all right, what are you cleaning with? Does it meet our system standards, or like, are they, you know, part of our system set of cleaning products? A lot of people will have access to order from things like Office Depot or other companies. So they think like just buying Clorox wipes from them is okay, you know, to buy and use in some of our facilities. So you want to kind of standardize the cleaning products right off the bat. This flyer right here is an example of what we did like our first month on the job, if you will. So we wanted people to be aware, like these are the different types of wipes that you are approved to use. We also included the ordering information because that's, you know, anytime you send out something that says you need to use this product, the email you immediately are going to get back, if you haven't included the information, is what is like the order number or how do I order this? So just include that right off the bat, and that'll save yourself a lot of time and questions. So that's really important. The other thing I mentioned is that some of these spaces are going to be leased spaces, right? You don't own the building, somebody else owns it, and maybe they have somebody else coming in to do the cleaning, or maybe even your leadership has hired an external cleaning company to come in. So you might want to touch base with them and see like, what are you using to do the cleaning? Does it meet our standards? Does it have appropriate kill claims? And then kind of try to standardize from there. Most companies or places in my experience are happy to comply. There's also been a few places where we've provided them our cleaning products and they just use those. So the staff show up, they use our products that we've provided, and then they go home and we know that everything's been cleaned the way that we think it should. Just an example, a horrifying example of one of the things that we encountered like right away was, since a lot of this had been unchecked, you know, forever, every clinic had a spray bottle of alcohol and it was labeled like the bed bug spray bottle. So if they thought they had a bed bug patient, they would spray the whole room down with, you know, isopropyl alcohol after. And so we had to eliminate that immediately. And we also took our bed bug policy and we updated it to include an algorithm specifically for the ambulatory settings, and also emphasize like no more spray bottles of alcohol. Here's what the actual process is. So other things to think about is, so if you have all this clinical staff at the frontline cleaning, you might want to make sure that they know how to clean, what to clean with, how to do it properly. Even at your ORs and your ambulatory surgery centers, there's not usually dedicated housekeeping staff. It's the OR staff who are doing the cleaning and room turnover between cases. So you might want to pop in there and make sure that they're cleaning everything the way they should. We even have like an audit tool that we're working on to kind of audit the room turnover. We also, with our last state CMS survey for a couple of our sites, they wanted us to have a dedicated policy to the ambulatory surgery OR cleaning and room turnover. So we had to put that together in the moment based off of like, you know, our other policies. So keep that in mind. The other thing that has really come up throughout the pandemic is people also have this expectation of like, I want a UV robot, or I want, you know, a sprayer of some kind or something. And leadership might approach you about that to try to, you know, comply with staff's requests. but you really have to talk to them about what does it mean to get a UV robot? How much is it? How would we use it? In most cases for ambulatory, a UV robot is not worth it, but something like an electrostatic sprayer might be. But if you're going to invest in that, you need to make sure that you also, have the staff to use it. They get trained properly. They know what PPE to wear. And you have to establish kind of an SOP, like where are you going to use this device to disinfect areas. So all things to kind of keep in mind. I'm sure that you've had these conversations throughout the pandemic, but now that we're kind of, seeing the light with the pandemic, this is still very much a real thing now that we all have to tackle. So keep that in mind. All right, if we move on to high-level disinfection and sterilization, this is your greatest vulnerability. I'm sure some of you have already started to notice this with, the latest rounds of surveys that are being done. But ambulatory does a ton of these things. Like every clinic, might have its own little tabletop sterilizer. They all might have a little reprocessing area to do things like Cydex soaking. And what you're going to find when you start heading out into these areas is there's a lot of people doing this stuff. There's a lot of variability because training and knowledge is going to vary. They're not going to have kind of the knowledge of what the process should be and what the current standards are. So you're going to find a lot of things that were like, well, this is how we've always done it. A vendor set it up for us like 15 years ago, and nobody has said anything to us about doing it differently. So we just keep doing it that way. So these are kind of all the things you're going to be up against. And then just to have the little cherry on top of the sundae is the IFUs, which I'll talk a little bit about in a second. But with more sites comes more variability in devices and equipment and more IFUs. So I'm sure you're all just like shaking your heads like, yeah, I know about those IFUs. If we talk specifically about soiled instrument handling, so just kind of for reference, we have hundreds of clinics that use instruments every day and that have to handle these soiled instruments and then get them reprocessed. So if you have, whether you have like individual clinics with tabletop sterilizers or you have a centralized process, either way, you're going to need a standard process for just handling the soiled instruments. So one of the things that we have is the system tip sheet where it tells you what exactly to do with the instruments where and how to get them to the reprocessing area. So for us, we did away with the tabletop sterilizers several years ago, like even before my team existed. And what we do now is we have all of the clinics and EDs and areas package up their instruments in these little red bins. They're spraying them with the appropriate spray, put them in a bag, they tag them, and then they either like walk them, down the hall to their SPD if they have one in the building, or they put it on a truck and it gets sent to one of their local sterile processing departments to be reprocessed and then gets shipped back to them. I think that's really the best case scenario. If you still are working with the tabletop sterilizers, you do want to try to get rid of those as soon as possible. But in the meantime, you're probably also going to have to make sure they have a standardized process of how are they manually cleaning them, how are they packaging them up, how are they sterilizing them, cooling and drying them, and then storing them. So those are all things to think about. And then obviously you'll want to push disposable or recyclable as much as you can. You will get pushback, but it's really key in this work. So for HLD specifically, so we have 65 plus sites that we audit for this. That includes scopes, probes, lenses, all kinds of stuff. So this is something we've been doing a ton of work on. I have another system tip sheet we have here just for our probes with our automated reprocessors. So I'm mentioning like system work. So we actually have a system reprocessing oversight committee that has different groups that work on this work. Ambulatory definitely bears the brunt of it. So we're involved in all of the committees, but it's a ton of work. And we have made a lot of progress, but we still have a lot of work to do, as I'm sure does everybody else. There are, when we talk about scopes, there are some disposable or recyclable options. It's still pretty limited. The visibility on the imaging is not always the greatest, so you will get pushback from providers. And then we've discovered there's also some billing issues sometimes. So you probably won't need to, or you won't be able to go disposable on this right away like you could with instruments. but something to kind of keep in mind and keep pushing for. There's also things like auditing, audit tools, auditor training that we've worked on. I think that's like a whole talk in itself, honestly. But all of that needs to be done as well, right? So what do you know about HLD if you're going out and looking? What makes you the expert? You need to know what you're looking at and what to tell people to do if you think they're doing it wrong. So keep that in mind. Competencies are huge. So make sure that you have competencies on file for everybody who's doing this type of work. And then I kind of alluded to the IFUs earlier. So another big thing you'll want to focus on and work with your leadership on is developing a process where if a provider wants to buy a piece of equipment or something, they have to have the IFU reviewed by you and maybe clinical engineering or biomed in advance to make sure that we can service the equipment, we can reprocess it, or even if they want to move a device from one site to the next, you should really do the same. We've run into areas where like something was getting Side-X at one site, they moved it to another, there was no ability to do Side-X there, and then it kind of like led services to a screeching halt. It was very problematic. Facilities and construction stuff. So this is also huge. We have built and opened 5 brand new buildings in the last couple of years. So this has definitely consumed a lot of my time. If you don't already have access to or a set of the FGI guidelines, you're definitely going to want to get one, and that's going to be your best friend. So we manage somewhere between 75 and 100 plus ICRAs every year because we have so many sites, there's so much renovation work going on. And when you start working in the ambulatory area, these people don't know about ICRAs, they don't know about construction precautions. So it won't be uncommon for you to walk into an area like this. So this is, I think, a cardiology clinic of ours, where there's no barriers and there's care being provided, like, off to the side over here on patients. So you need to work with your facilities design and construction teams to start, getting yourself included in the projects as soon as they start coming up, because you need to be involved in the design as well to make sure they're complying with the FGI guidelines and other regulatory requirements. Then you need to work with the contractor to make sure there's appropriate barriers in place, obviously. And then the extra layer of complexity when it comes to ambulatory is you're not going to be on site every day to monitor this work. So you need to empower the people at the front line to keep an eye on this for you. So we have like a little checklist that we give local leaders to complete every day to kind of look for things like dust, are there holes in the barriers, things like that. If there's any complications, like here's who you call for help, like one of us. So, keep that in mind. It's a little bit more complicated. The other thing that's going to happen on probably almost a weekly, at least monthly basis is you're going to experience floods, leaks, boil water advisories, loss of water pressure, HVAC issues like no air conditioning in the summer, no heat in the winter, power outages, and then even a fire from time to time. This is actually a picture of last summer, one of our medical centers, the rooftop deck caught on fire. So the fire department showed up, 10,000 plus gallons of water went through the building from the 3rd floor and then pooled in the basement. The whole building had to be remediated. So I got the call at like 5 o'clock that the leader, of the building was on his way to the building. He's looking to me for guidance, asking if we have a playbook on fires. I'm not the right person to call, but I will be there tomorrow to help you with remediation. So the next day we were there walking through the building, talking about the remediation. The whole building basically had to be gutted and rebuilt. So we were involved in all that work. And since ambulatory doesn't have a lot of resources and dedicated people to do stuff like this, if they see you as a source of information and the people who know things, you're going to be included on these calls and questions all the time. So we open up local incident commands frequently for these types of things, and that happens at all hours of the day and night. It's not uncommon for me to be doing my hair in the morning and get a frantic call or an incident command put on my calendar to join immediately to provide guidance for these types of things. It's also happened at like 11 p.m. too, like on Halloween. So to kind of save yourself some trouble, I would highly recommend that you build yourself some tip sheets. So the basics of these things are going to be the same no matter what facility you're working in. There may be some differences, like if there's specialty services or an ED attached to the building, your response, might need to be a little bit more complex. Typically, if you are talking to like one of your acute care peers about something like, we had a water go out at a clinic or power outage, the easy response is, or even from like a hospital leader, like, oh, just shut down the building. Usually you cannot shut down the building because you might have patients like receiving infusions, you might have people anesthetized, and especially right now with finances being the way they are, leaders will do anything they can to keep a building open the best that they can to provide services, and bring in as much money as we can. So you usually can't just close the whole building. Other things to kind of keep in mind. So we always partner with our regulatory risk and employee safety people and things like this. They're always part of the automatic incident command list of people that get contacted. And then we do have our tip sheets available too. So it definitely helps the local leaders to just send them a tip sheet. You don't have to keep reinventing the wheel, and they find that really helpful. We do also have policies that are associated with the tip sheets, but people don't go to the policy, they go to the tip sheet. So I think this is my last section. I'm going to try to be really quick. So we do have ambulatory surgery centers that does come with some surveillance. So we don't do CLABSI-CAUTI or lab ID like everybody else, but we do SSI. It's not required, but this is something that the state CMS surveyors have been asking for more frequently, and they're kind of starting to expect it. So we do use NHSN's outpatient guidance and documents to do the surveillance. It's very similar to what you're used to doing for like colo and HIS on the hospital side, but you don't actually have to use Chapter 17. So it's easier to call an SSI outpatient than it is inpatient. In terms of the ORs and the ASCs, we do a lot of auditing. So we do auditing ourselves, but then we also have audit tools that the local leaders have to do on a weekly basis. So those are for things like, the surgical scrub of the surgeon, skin prep on the patient, adhering to aseptic technique. We look for environmental care type issues. And then we also do like monthly SPD audits that we rotate among the sites. And then in addition to that, we do collect SSI data. We are working on like what we do with that data, right? So it gets disseminated, but we don't have a ton of work happening with it right now. So that's something we're working on. But we do have an RCA tool that we have put together. And as the complexity of cases grow, it's really important to like know what's going on at your AFCs, who's doing what, key contacts, things like that. You really want to have eyes on these things. And then when it comes to the surveillance itself, there's nothing that says you have to perform surveillance on these cases or those, right? Like you kind of have for the hospitals. So what we did was we looked at our highest volume cases, things that we knew we were already having problems with, and then we automatically included hip and knee because our hospitals do surveillance for those. So we wanted to be able to make comparisons. So that's kind of how we came up with the list of what are we going to do surveillance on. And it also varies by site because every ASC focuses on different types of cases. They're not all the same, so keep that in mind. And then just for fun, a lot of times private providers will lease OR space. So for example, one of our ASCs, 40% of the surgeries that are performed there are by private providers. So we don't require them to report. We do have an SSI fact-back form to kind of help us just to detect, like, is there something else going on with our OR or SPD maybe? They really don't do it. It's a nice idea and something we might try to promote in the future, but just know that there are private providers also utilizing your spaces. All right, last thing to kind of quickly try to like wrap up with. Education is one of the most important things. So you're not going to be able to do face-to-face education for everything like you would usually on the acute care side. You have to really leverage technology and electronic stuff to help you. So we have a standard template. So if we're going to communicate something, we call this our spreading the news, haha. And we put the information on here. We blast it out to everybody we have on our listservs, just to kind of distribute the information and get it as far as we can. We also have other things that we do, like every Wednesday we send out our ambulatory quality and safety bites. So these are different like quality related things, right? Infection control stuff, we have regulatory stuff, we have risk things, medication management, other things. It's different every week, and all of us from the quality department contribute to these. So it's kind of helping with our continued regulatory readiness. So I mentioned the importance of having a website, the distribution lists. When you're rolling out a new process, especially if it's a big process or a new concept, you might even want to do webinars where you kind of open it up. Maybe you do a little PowerPoint, you know, prepping them on the process or the change, but give them a lot of time to ask questions, because that's going to be key for you. We talked about the little tip sheets. I'm looking at the clock. I know we're getting short on time, so I'm going to go a little bit faster. Isolation, just a heads up, pre-pandemic, no one in ambulatory really knew anything or heard anything about isolation and PPE. Because of the pandemic, yes, they know about like COVID PPE and protocols, but they are not really going to know about other things necessarily, like TB or pertussis or C. diff. So you'll probably want to make some user-friendly signs. So we worked with our hospitals to standardize and update our system isolation signs. So they're really nice little infographics to tell you what type of PPE you need when. There's basic info on donning and doffing, and then we also have QR codes for education for both staff and for families or visitors if they want it. But this is going to be key, and you want to start this education with your primary care, peds, and urgent care walk-in clinics, but then expand it out from there. Like, you never know who's going to encounter somebody who may need to be isolated. So keep that in mind. And you're really starting at the beginning. So don't assume that they know anything like your inpatient unit staff would. Lots of tip sheets with pictures are really helpful. We all, like including our hospitals, all have an ISO made easy. So this is kind of like the different types of isolation, what to do, whether it's like hand hygiene, what PPE to use, what to do with transport, visitors, all of that good stuff. For us, we have the same EMR system. I don't know if I can say the name, so I'm just gonna like allude to it. We have the same EMR system as like the Beaumont Corewell people. So this allows us to have a functionality for infection flags and isolation flags. So if someone tests positive for something, or they're diagnosed with something like on a problem list within a communicable disease isolation window, they'll automatically have a flag that pops up that says this person, you know, recently tested positive for this. They may still require isolation. Here's the type of isolation they need. It talks about donning, doffing, room turnover, all of that information. There's links to like helpful policies, and then also all of our contact information in case they want to phone a friend. So that's really helped us reduce our exposures in the clinics. Finally, we have hand hygiene. It's very different. We do we can't really do self-observations, so we have patient observations that we do. They fill out this little form, they hand it back. The clinic staff at the front desk will put this into our a survey tool, and then we have dashboards that automatically calculate all of this for us, just like the hospitals. That's been really great. Regulatory compliance and emergency management, also super important. You're going to be involved in lots of surveys. Policy is huge in order to get the ambulatory information incorporated. So if you can be included in those policy things, in those groups that work on those, that's key. And the same for emergency management. Your incident command is usually hospital people sending out information for hospitals. So you need a presence on those in order to include and accommodate the ambulatory areas. So quick wrap up, this is a marathon, not a sprint. You're not going to be able to do this alone, so just try to take it day by day. And if you need help, you can contact us here and we are happy to help you. And I'm going to end there. I'm sorry, I'm like at time.
Well, thank you, Jenny. I think I speak for everyone who joined us today when I say this was a wonderful presentation. Lots of comments in the chat about how great this presentation is, and everyone is suggesting that this should be presented at National APIC. So I don't know if you submitted for next year, but we hope you will be presenting at National next year. And thank you so much for taking the time to share your knowledge, your experiences, and your lessons learned with us from the ambulatory world today. The content was very practical and it was great. Because we are short on time and losing participants, there were several questions that was dropped in the chat. I will compile the questions, Jenny, and then I will send it over to you to answer those questions, and then we will share that with the chapter members along with the slide deck for today.
Sounds good.
Kelsey, did you want to bring up the screen? We do have 2 quick reminders before we close today's session. If you have a job opening you would like us to share, please email Rebecca with the information, and Rebecca can post the job opening on our APIC Great Lakes website. And then one more reminder is that don't forget to subscribe to our APIC Great Lakes YouTube channel. Today's presentation was recorded and will be posted shortly in the next day or so to our YouTube channel. And then once again, thank you everyone for taking the time to join us in today's session. We appreciate everyone as always. And if there are questions, please feel free to reach out to Kelsey or I at the email. Kelsey, do you want to move forward to the next slide? Here. So thank you for being a part of APIC Great Lakes. We hope that you guys all have a great Thanksgiving. And be safe, everyone. Have a great rest of your afternoon. Thank you again, Jenny and the Henry Ford Health Ambulatory team for a wonderful, fantastic presentation today.
Thank you so much. Have a good day, everybody.